Good morning, and thanks for joining us for this webinar. We're going to give it just a minute or two for people to get a chance to grab a cup of coffee and hop on, and we'll get started. Good morning. Thanks for joining. We'll give it just another minute for folks to hop on, and then we'll get started with this morning's webinar. Thanks for joining us. All right, good morning. I have two after the hour, so let's get started. Thank you for joining today's Shot of Knowledge webinar from the Rhode Island Immunization Program. This is Prevention Starts Sooner, HPV Vaccination at age 9 in Rhode Island, and we're glad that you've jumped on the call this morning to talk about what has happened with HPV vaccine over what's been a very remarkable 20 years and what we can be doing looking ahead to improve those cancer prevention rates with HPV vaccine. Next slide, please. So just a few housekeeping things. This recording will be available on the Rhode Island Department of Health's website after the close of the webinar. The views of the presenters here are their own and do not necessarily reflect those of their respective organizations. If you have questions, and we hope you do, please put those in the Q&A box and ask those questions of the presenters. And feel free to do that at any time during the presentations, and we will get to as many of those at the end of the webinar as we can. And then please take just a few moments to answer the survey questions that will pop up in your browser at the conclusion of the webinar. That helps us understand the kind of content that you would like to see and what can be most helpful. Next slide, please. So today's agenda, we just went through some brief housekeeping. We've got some learning objectives to cover. Then I'm going to talk a little bit about HPV vaccine history, and then there'll be some comments on the benefits of starting HPV vaccine series at age 9, some Rhode Island HPV data, and some provider insights. And then we'll get to question and answer, and this will all fly by as these things always do. Next, please. And as far as learning objectives, we're going to talk about explaining how HPV vaccine is recommended and about HPV vaccine coverage in Rhode Island, understanding the current research that supports starting HPV vaccination at age 9, and identifying effective communication strategies for discussing HPV vaccine series with parents and caregivers, emphasizing trust, clarity, and clinical expertise. Next slide, please. So I am the lucky one who gets to start and moderate this webinar. I'm Dr. Shelley Fiskus. I am a pediatrician, and I'm the Chief Medical Officer of the Association of Immunization Managers, a partner of the Rhode Island Immunization Program. We are excited, as I said, to bring this information around HPV vaccine to you. This is something that I have been personally passionate about for the last 20 years. Then we'll hear from Dr. Lisa Gargano, who is the chief of the Office of Immunizations at the Rhode Island Department of Health. She holds a PhD in immunology and an MPH in epidemiology from Emory University and has more than 15 years of public health experience in infectious disease epidemiology, vaccine preventable diseases, and immunization program leadership. Dr. Gargano founded the Rhode Island Vaccine Equity and Confidence Unit and has led statewide initiatives focused on improving vaccine access, confidence, and uptake across diverse populations. And then we'll hear from Dr. Danusha Dietrich. She is a board certified pediatrician and a fellow of the American Academy of Pediatrics and currently chairs the Pediatric Steering Committee at Rhode Island Primary Care Corporation and serves on the board and Practice Advisory Council for Reach Out and Read in Rhode Island. Next, please. So let's get started and talking a little bit about what we've had with HPV vaccine over the last 20 years. Next, please. And just a quick disclosure, my association, the Association of Immunization Managers, does accept educational grants from pharmaceutical companies that manufacture vaccines, but those companies do not have influence on the content of our assets, and AIM does not endorse any specific brands, products, or companies from industry funders. Next, please. So HPV, over 200 related viruses and 12 high-risk types that we generally focus on, 16 and 18 that cause the majority of HPV-related cancers, 6 and 11 that cause most genital warts, and then a few strains thrown into the vaccine that contribute to about 10 to 20% of cervical cancers specifically. And HPV virus causes 6 types of cancer that we know of so far. Nearly all cervical cancers, nearly all anal cancers, and then most vaginal, oropharyngeal, vulvar, and penile cancers. Next, please. And this vaccine has had a tremendous impact over the last 20 years, and we're really starting to get some good, rich data around the power of this vaccine. So in the United States, over the last 20 years, we've seen a 27% decline in cervical cancer rates in women ages 20 to 31. And states that have higher vaccination rates tend to have greater declines in cervical cancer rates. And interestingly, for every 10-point increase in vaccine coverage, we're seeing an 11% greater decline in cervical cancer. And if you'll click again, if you look at this graph, you'll see that you have states that have high vaccination rates and low cervical cancer incidence rates all the way to the right lower quadrant. And there's Rhode Island leading the pack in all of this, which is just amazing. Next, please. And then there was just a study published from Sweden that is a population-based study of more than 900,000 girls and women who received HPV vaccine, at least one dose, versus individuals who were not vaccinated, and showed that there was a significant difference in cervical cancer rates among those individuals who were vaccinated, and no indication that that protection has been waning over time. Next, please. So the current recommendations, and these are the CDC recommendations from July 29th, 2024. These are the current recommendations from CDC, that we have routine vaccination at 11 to 12, but that can start at age 9. That catch-up vaccination is considered ages 13 to 26. So we really want to have the full series completed before the 13th birthday. And then there is an option for shared clinical decision-making for individuals ages 27 to 45 who might be interested in being vaccinated or who might be considered at high risk for HPV infection. And then note that HHS made changes to the schedule on January 5th, 2026, but those changes were stayed by the federal court in March, and that's why CDC has reverted to these recommendations of July 29th, 2024. These predate any decisions that were made by the most recent Advisory Committee on Immunization Practices. Next, please. So the CDC recommendation is to start ages 9 if possible, but through 14 years, they can get by with just 2 doses of HPV vaccine, 6 to 12 months apart. Again, really trying to get both those doses in before age 13. Next, please. Ages 15 and older, or anyone who's immune compromised for any reason, should get 3 doses at 0, 1 to 2 months, and 6 months. And it's okay to administer these vaccines to lactating or breastfeeding individuals. There is not an indication to administer them to pregnant individuals, although we wonder if that might be coming down the road sometime in the near future. And then again, these do not reflect the changes that were temporarily made to the schedule on January 5th. Next, please. So to say HPV vaccine history is complicated is probably an understatement. So, in June 2026 or 2006, so almost exactly 20 years ago, we got our first HPV vaccine that was approved for females only, ages 9 to 26, and just had 4 strains available. And as that was approved, the then Texas governor decided that he would be making an executive order that every schoolgirl needed to get an HPV vaccine. That was met with not a lot of warm fuzzies from the people of Texas and from the legislature. And the legislature actually voted to ban the HPV vaccine for about 4 years. Next, please. And then go to the next, please. And so the governor eventually ended up backing down by late 2007 on this initial measure to mandate that vaccine for young girls. But when he was running for president in 2011, this was still one of the major campaign criticisms of him. If you'll go to the next, please, um, that he was the one who created this executive order to try to mandate this vaccine. And if you'll click one more time just to highlight that headline, in 2011, so 5 years later, he was still hearing about this misstep that he took to try to mandate this brand new vaccine. And this really set a lot of us back in our ability to be able to effectively recommend and get our patients vaccinated. And now we are 20 years later and still not at the rates that we would like to see. Next, please. So there was public pushback in Texas and other places. And in Texas, they had an abstinence only policy in their schools as far as sex ed. And so the statement was that HPV vaccine gives tacit approval to premarital sex. And this is my favorite HPV related cartoon. Which is this poor girl who is just trying to get vaccinated, apparently in the elbow because cartoonists don't know how to administer vaccines. And it's saying critics claim HPV vaccination will lead to promiscuity. And this poor little girl saying, "Oh, I'm so turned on right now," because it was so ludicrous to expect that getting a vaccine that is going to protect you from this virus would cause you to have premature sex. So the long-term effectiveness of the vaccine at the time had not yet been established, and there were concerns that we just didn't know what would happen down the road. A lot of claims around fertility concerns and all of that that caused people to hesitate to get vaccinated. And then also in the same year, we have this rise of Jenny McCarthy and her Green Our Vaccines campaign, given a lot of oxygen by Oprah Winfrey to be able to talk about how she felt that vaccines caused her child's developmental disability. And if we click to the next, at the same time, we had this massive rise in social media. So Facebook use going from 12 million users in 2006 to 50 million users in 2007 and 100 million users by the end of 2008. And as we know, misinformation travels at the speed of the internet, and the truth is still putting its shoes on. So all of this just created this sort of perfect storm for our inability to get this vaccine into the people who needed to be protected most. Next, please. And so all of this that was caused in Texas was probably not worth it. As you can see, the Texas immunization rates in the lighter blue there are have been among the bottom. And in 2008, shortly after this, there was no great uptake of HPV vaccine in Texas because of this mandate that had been put in place. Next, please. So the indications for HPV vaccine have also been kind of confusing and hard to keep up with. So again, first vaccine in 2006, in '09, It was approved for males who had been excluded from prevention before. And then in 2014, we got Gardasil 9 that protected against more subtypes than Gardasil 4 and had different age recommendations for girls versus boys. And then in 2019, we got the expanded use with shared clinical decision making into young and middle-aged adults. And then in 2020, we finally got the indications to move HPV vaccine indications beyond just prevention of cervical cancer. So it seems like we've had that indication forever, but it's really just been 6 years. And then in 2024, really starting to see this data show about the impact of the vaccine on cervical cancer incidence rates, and hopefully we'll begin to see more data on its prevention of other HPV-related cancers. But at the same time, we're still seeing messages like this on social media. HPV vaccines been given to boys. Boys don't even have a cervix. Question everything. And so the messaging isn't getting down to the public who needs to hear it. Next, please. And then we had this little pandemic that popped in the middle of all of this, and HPV vaccine really took a hit as adolescent care was pushed out to be able to get younger children into the office and get their primary series vaccines done, their school vaccines done. HPV took a hit along with the other adolescent vaccines and is still in the process of recovering from 2021. Next, please. So when we look at the trajectory of this vaccine over time, the top two are one dose in males and females. The bottom two are up to date for females and males. Sorry, females on the top, males on the bottom. And we can see that we've got males and females almost at the same place now, which is great, even though males got a much later start. But we've been a little stagnant in this kind of right below 80% range for the past few years. And again, the pandemic didn't help. And if we layer on this, the rates of Tdap and meningococcal vaccines, which you see in the green and the blue at the top here, all three of these vaccines should be being administered at the same visit if they're all being recommended at age 11, as they should be. And we see that there is still this disparity between HPV vaccination and the other adolescent vaccinations that we give. And so we need to do something more to improve those HPV vaccination rates. And that's where vaccinating at age 9 can come in. Next, please. And it's not just been here in the US that we've had these kind of struggles. Japan had stopped HPV vaccination completely for a while. We had trouble in Brazil, go ahead and click through these. In India, there were hesitancies. Brazil, as I said, and then in the Danish HPV program, all of these countries have dealt with the same misinformation and political pushback against giving HPV vaccines. And so this is not a solely US issue. Next, please. There have been some state policies that have been put into place to improve immunization rates, and you can see Rhode Island right here, again, leading the pack at 92.7% for both males and females for at least one dose. Other jurisdictions that have school age requirements in place are DC, Puerto Rico, Hawaii, Virginia. All of these states are well ahead of the US vaccination rate, and likely in part at least due to these policies that have been put in place. Next, please. So HPV at 9, which we're going to talk about a lot today, we find that HPV vaccine is most effective in cancer prevention between the ages of 9 and 12. It reduces the number of shots at age 11, which sometimes is something that we hear in the office. Oh, only give me the ones that are required at 11 for school. That's where that school requirement comes in handy sometimes, but it pushes HPV vaccine to age 9 where there are no other vaccines unless they're getting flu and COVID vaccines in the fall. Easier conversations with parents because we're not so focused on the whole idea of this being a virus that can be transmitted sexually. And at the very least, it encourages that we're having conversations at a younger age so that even if they say no at 9, we're talking again at 10 and 11 and 12, and really hoping to get that vaccine in and completed before the 13th birthday. Next, please. So this is my favorite kind of HPV equivalent meme. This is where we started in 2006, and then click again. This is kind of where we are now in 2026. I love dogs. This poor spaniel, so close, and then womp right at the end. I feel like that's kind of where we are, that we've had these stops and starts and a lot of really big bumps and or weave poles in the way that we've sometimes conked up against. But we're so close to getting to a place where we are protecting every person from HPV related cancers. So I will stop there, and please feel free to put any questions in the Q&A box, and I will hand it over to Dr. Gargano. Thanks.
All right, thank you, everyone. Good morning. I'm going to go through some Rhode Island specific data for us all is around HPV vaccine, but also HPV vaccine at 9. So our recommendations here in Rhode Island align with the American Academy of Pediatrics as well as CDC's, and that is that adolescents 9 to 14 need 2 doses to series completion. Adolescents 15 to 26 need 3 doses, and that adults 27 to 45 can get vaccinated based on shared clinical decision making. The current product, Gardasil, or for HPV-9, is not FDA approved for anyone older than the age of 45. And these recommendations, as Dr. Fiske said, are both for males and females. And we do offer Gardasil as part of our state supplied vaccine program. Next slide. So back in January, as was previously mentioned, HHS had made sweeping changes to the childhood immunization schedule. One of those changes was around HPV vaccine. The vaccine continued to be recommended for all children, but it was reduced to a single dose, regardless of age. And as mentioned, that schedule has received a stay in Massachusetts court, and the previous schedule from July 2025 is the one that's currently in standing. And so, but I wanted to mention a few things around this single dose. And while there is a growing body of evidence, high quality evidence really suggesting the efficacy of one dose in certain age groups, to date, HPV vaccine is not FDA approved for one dose. Again, our recommendations align with AAP. The previous ACIP's, I guess, ACIP's HPV vaccine work group was reviewing data on a single dose HPV vaccine. And so this was something that was under active investigation. And recently, the Vaccine Integrity Project and other professional organizations have been reviewing safety and effectiveness data of a single dose HPV vaccine. And the VIP's report was pushed out a couple of weeks ago, and we'll put that link in the chat for those who might be interested. And the bottom line of this report was that at this time, there's really not enough evidence to support a move to a one dose here in the US. Next slide. Next slide. So, okay. So as was mentioned here in Rhode Island, we do require HPV for school entry. Again, we're one of 3 states, and then Washington, D.C. and Puerto Rico, who have some requirements on the books. The requirements here in Rhode Island are done via state regulation. We allow for medical and religious exemptions in schools. And it was advised that schools not exclude those students who maybe were not vaccinated or did not have an exemption. Normally, you either have to be vaccinated or have an exemption on file to stay enrolled in school. But there was advisement at the time of the implementation of these requirements that schools not exclude students when it comes to HPV vaccine and these requirements, to continue to work with parents to hopefully get that child vaccinated. And so these requirements ensure progress here in Rhode Island towards protecting against HPV-associated diseases. And at the bottom is our timeline on how these requirements came to be. It started in 2013 with buy-in from partners, town hall meetings done in the community to hear community questions and concerns. And then in July of 2014, the regulations were passed with an implementation date of August 1st, 2015, where it was a rolling process. So that first year, one dose was required for seventh grade entry. And then the following fall of 2016, two doses for eighth grade entry. And then finally, at the fall of 2017, the series must be completed, one or two doses by ninth grade entry. Next slide. So this is some of our data here in Rhode Island that show over time our HPV coverage rates. So on the left is at least one dose of HPV, and on the right is up to date. So one or two doses, depending on age and when that recommendation came into effect. And in the red is females, and in the bluish color is males. And the red arrow indicates when our school requirement was implemented. And so you'll see even prior to our school requirement, we had very high coverage rates here in Rhode Island. But then those did increase both with at least one dose and up-to-date rates for both males and females after the implementation of the school requirement. And as was mentioned, these rates are well above what the national average is. Next slide. So one question that we always get is, well, what did the school requirements do to your religious exemption rates? So that's what this graph here shows, our seventh grade religious exemption rates. And so in the blue is any religious exemption for any vaccine. And then in the reddish color is HPV specific exemption. And so again, the red arrow indicates the implementation of the school requirements. And of course, before the requirements, it was only all the other vaccines. And so we had very low religious exemption rates. And we did see a significant increase immediately after the implementation of the school requirements. But you'll see that that rate has gone down over time. Next slide. So over the past few years, we've done a lot of data collection here in Rhode Island to assess Rhode Islanders' knowledge, attitudes, behaviors around a variety of vaccine-related topics. One online survey that we did a couple of years ago, where we looked at Rhode Island as well as a national sample, we found that 60% of Rhode Island respondents strongly agreed that HPV should be required for teenagers in school, and that was compared to 52% of the national respondents. In addition, we collaborated with several of our health equity zones, the Rhode Island Public Health Association, and the Partnership to Reduce Cancer in Rhode Island, and the department's breast and cervical cancer screening programs to conduct several focus groups across Rhode Island, assessing HPV vaccination knowledge and behavior, as well as cervical cancer screening practices. And from those focus groups, we found that participants overall reported a positive experience in getting HPV vaccine either for themselves or for their children, with a low barrier of access reported. So that was great to hear. Overall, there was a high support for HPV vaccine among participants, but they did express a need for more public education on HPV vaccine, particularly around the cancer prevention benefits of the vaccine. Next slide. So, as Dr. Fiskus mentioned, as coming out of the pandemic, nationally, we saw vaccination rates fall as provider offices were closed, schools were closed. And so when we looked at our coverage rates among pediatric vaccines coming out of the pandemic. We saw that we were beginning to catch up, but HPV vaccine was not catching up as quickly as the other vaccines were. In addition, the discrepancies of who was catching up was more apparent, and larger discrepancies seen in HPV vaccine than was seen in other vaccines. And so we decided to focus on HPV vaccine to try to push those coverage rates up and do what we could do to catch up to close to pre-pandemic levels as we could get. And so what we did was we conducted a geographical analysis where we identified what we call hotspots. So these are small geographic areas where we are looking for coverage rates that are lower than what the state average is. And we found 8 hotspots in Rhode Island across the state. Some of these were expected, where we anticipated having lower coverage rates, and some of them were not. And you can see in the red box that those hotspot communities, about 55% of those adolescents were overdue for at least one dose of HPV vaccine, compared to just under 39% in all the other communities. And so this map helped us target our outreach and work within those communities to tailor our outreach language-wise, work with community-based organizations, and really do hyper local focused education and outreach around HPV vaccine. And so that has been really successful in getting our vaccination rates back up post-pandemic. Next slide. And so I'm going to last few slides here focus on where is Rhode Island when it comes to vaccinating for HPV at 9 to 10 years old. So of all of our first doses administered here in the state in 2025, about 12% were given to children 9 to 10 years of age, compared to about 61% for 11 to 12. But as you can see in the bar graph below, the percent vaccinating at 9 to 10 has been increasing substantially over the past couple of years. And so that is really encouraging as more of you and more healthcare professionals take up this vaccinating earlier initiative. Next slide. And then the really interesting thing also comes into who is getting vaccinated at 9 to 10 here in Rhode Island. And so on the left looks at vaccination, the percent starting at 9 to 10 by race ethnicity. And so we can see that Hispanic children and Black non-Hispanic children are getting vaccinated at 9 to 10 at higher rates than their white non-Hispanic counterparts. And then on the right looks at this by insurance coverage type. And so here we see that children on Medicaid also are significantly more likely to start vaccinating for HPV at 9 to 10 compared to those children with private insurance. And so this just gives us an idea of what type of populations, what type of outreach and education and communications we need to do. And I think that's it. And I'll pass it over to Dr. Dietrich.
I thank you for inviting me. What was not in my bio was that I was actually on the RIDOH Vaccine Advisory Committee during the time that HPV was getting introduced into Rhode Island. So I'm actually pretty proud to have been part of the group that advocated for and helped implement the school mandate for HPV vaccine in Rhode Island. I feel really strongly that this was such an important vaccine for the health of both Rhode Island and all children. So one of the things that we have done in our practice starting last year was to shift our focus from giving the HPV vaccine routinely at the 11-year visit with the other required vaccines of Tdap and meningitis vaccines to the 10-year visit. And we started the conversation after I believe a shout out to Michael Koster. I'm going to a talk by him on the efficacy of trying to start this conversation earlier. And so we shifted last year to implementing routine vaccination of HPV at the 10-year visit. In terms of what has been effective in my practice, we always, we had pretty good uptake at the 11-year visit, with some of the barriers being the same as everybody's seeing, with some pushback from families. But the school mandate has been a big help in that conversation in general, because families who are hesitant, if I could say very firmly that not only do I recommend it, but it's a school requirement, they often say, "Oh, okay, didn't know that. Sure, go ahead and give it." But one of the benefits I've found at starting earlier is that you can really focus the conversation on the cancer preventive benefits, and take out, as was mentioned by one of the earlier speakers, some of the concerns that parents have about whether it's permissive for them, their child to suddenly have sex. And I think that conversation is easier to have when they're younger, because they're not even thinking about it at that point. At the 9-year visit, we haven't implemented it, giving it at the 9-year visit, but we have started discussing it at the 9-year visit, that they will be getting the vaccine at the next visit. And in terms of what is effective for me and my practice, is really targeting the conversation around the cancer protective benefits, not only for cervical cancer, but also for the other cancers that HPV has been shown to be effective to prevent. And my personal approach is that I actually address that conversation to the child at 10. Most 10-year-olds are pretty savvy and are able to engage about these conversations. They're not particularly happy about getting a shot, but when you can explain to them that it is preventing something really serious like cancer and will keep them healthy in their future, they're usually actually pretty much more open to getting the vaccine. And the other piece of that is parents are also more open to the conversation when you present it in the context of a vaccine that prevents cancer. A lot of women have had their own experiences with cervical dysplasia, or had a friend who went through that. So I think that resonates a lot more with families than talking, in talking about this vaccine. I do obviously still have some families that are hesitant, and we try to continue the conversation every well child visit, until they're no longer in our practice. And I think that is also part of the methodology that really helps families understand that the provider really recommends and encourages this vaccination, and that we're not going to just let it go. And I tell them, I'm going to keep asking you, and I'm going to keep talking about it. And, if you have questions, please bring it up. So I think that generally has been a very effective approach in our practice. Um, I'm not sure our exact numbers right now, but we did do a quick poll, and of our 9 to 19-year-olds, about 65% in a quick poll of our data in our practice have completed the entire series, which is pretty good. I wish it was higher. I hope it is higher, because data pulls from Epic EHRs are difficult, but I think we're doing fairly well. And I think the other thing that has been effective is we present it very much as routine vaccines, just like we do every other vaccine, and try not to differentiate it from any other vaccine that we present for consideration by our families. Uh, I think those are my main points that I wanted to make. And I'm happy to take any questions about practical applications or approaches to patients. And I really appreciate being invited to speak at this webinar. Thank you.
Thank you so much, Dr. Dietrich. Um, I was wondering, did you have any pushback from your partners in practice when I assume it was maybe you who brought forward the idea of moving it to age 10? What was the opinion of the others that you practice with?
Sure. So I have the good fortune of being the main physician and owner of the practice, and I have two mid levels. So our there was no pushback in the sense that our practice has always been very pro-vaccine and discussing both not just my practice partners but my staff. We are all very aligned in the importance of vaccination. And so there was no concern for that in my practice.
Does help to be the boss.
Yes. But I think setting a tone that it's important is really key because if we don't believe in the vaccines, our patients are not going to believe in the vaccines. So I think it really is important to set a culture and a tone of expectation that these are important ways to keep, that we keep your child healthy and having alignment across staff, providers, and is really key, I think, to giving families confidence that they are doing the right thing for their child.
I'll invite any of our participants to put questions into the Q&A. We're happy to address those, but I wanted to stay kind of on that path with you, Dr. Dietrich. So when in my practice, it was sometimes someone at the front desk who sort of poisoned the well. I would have a parent call to schedule an appointment. They would ask what vaccines were going to be given at that appointment. And the response would be something like, well, you need the tetanus, Tdap vaccine for school, and then you should get a meningitis vaccine because meningitis is terrible. And then, I mean, if you want to, you can get an HPV vaccine, but I didn't get it for my kid. What do you do to create that culture amongst all of your staff in the office?
So I think we have, fairly often conversations around vaccines in our office at staff meetings, and they also know. So I actually did a 3-year fellowship in infectious disease as well, so they knew coming in that I'm going to take a pretty strong stand on this, and so. I've been fortunate that my current staff, we haven't had a lot of turnover, so they've worked with me for many years, and so they 100% know where we stand on this. And I think part of it is just being really clear when we're hiring and when we're discussing vaccines in the office that it is extremely clear to everyone. It's a small office. I only have 6 employees, 7 employees that are, 2 that are clinical. But front desk also is very aware, that we are very focused on this as a public health initiative that is incredibly important. And so I don't think anybody who was undermining our vaccine messaging would be working for me very long. So I guess I have a lot of control over my practice because of that, unlike some places. But, I think part of it is just setting a very firm expectation that we are all going to be on message. And the MAs, for example, we always provide the VIS sheets, at the physicals where the well childs where families are getting, children getting a vaccine, and they're very upfront with, my MA is very clear on you're getting Tdap, meningitis, HPV, they'll just hand them the vis. It's not a conversation about permissiveness or should you get it, it's just like this is what you're getting today, and if you need, and you can discuss it further with the doctor if you have any questions. So I think it's just we keep it very simple in our office with our messaging because I think that is the most effective way to make it feel routine, and to make it not feel controversial. So I think everybody has pretty clear on that expectation in my office. And as I said, I think if there was somebody who didn't believe in that messaging, they wouldn't stay employed with my office. So I don't know if that answers your question in a way that helps you because you may not have control over your hiring practices, but that is what has been effective for us.
Yeah, yeah, it's so important to be intentional about these
Yeah.
things, and just like we wouldn't allow someone or be okay with someone not putting their child in a car seat that was rear facing. This needs to be just matter of fact in the exact same way that we talk about car seats or bike helmets or any other safety thing that we discuss. Um, if Dr. Gargano is still available, I wanted to ask a little bit about non-traditional vaccinators or people who are talking about HPV vaccine that might be sort of out of the box for where those conversations usually happen. I was recently at a meeting where a dentist in Connecticut or Massachusetts, one of those states up by you, was actually giving HPV vaccine out of their office and was in the Vaccines for Children program, which is just amazing that she was doing that. So, have you had any success working with dentists or other sort of, out of the box, non-traditional providers in talking about or administering HPV vaccines?
Yes, yeah, we work very closely with our oral health program around HPV vaccine. We have an oral health coalition here in Rhode Island. They do an annual summit conference, and we are present to provide resources around HPV vaccine, specifically tailored towards dentists and dental hygienists to help have those conversations around oral cancer, tongue cancer prevention. We have tried in the past to get them enrolled in our program. As everybody, many on the webinar know, the storage and handling. We don't, Universal does help when it comes to enrollment, but we continue to try to work with non-traditional providers to provide every access point that we can where people might interact with the medical community in some capacity. But we do work a lot with our oral health program to help promote HPV vaccine.
What about school nurses? Have they kind of gotten in on the conversation?
Yeah, our school nurses are great. We have a fantastic program, the Vaccinate Before You Graduate program. It's in middle and high schools here in Rhode Island, where the child can get caught up with any routine vaccine at school. And so we have a lot of school nurse teachers who promote that heavily as a way to help that child catch up, especially as they get older and they're getting ready to graduate high school and move on from there. And we also have many of our university health service centers enrolled in our state supplied vaccine program. And so if they are coming from out of state, or maybe if they did not get vaccinated while they were a minor, they can then get vaccinated at the Student Health Service Center as well.
That's amazing. That's where your universal program is such an advantage to getting kids vaccinated in school, and there's so many barriers to getting college students vaccinated through student health because they a lot of times don't have a billing mechanism, and those are kids that no longer qualify for vaccines for children in a lot of cases if they're 19 or older. So that's got to really help with getting kids vaccinated at school at whatever level to have that universal program in place.
Yep.
So anyone who wants to put a question, you can do it in the Q&A box, and we will be sure to try to get to all of those before we wrap with this webinar today. I also was curious about religious exemptions in Rhode Island. So are there hoops that parents have to jump through to get a religious exemption? It was interesting to see the religious exemptions actually declining over the last 10 years or so in Rhode Island. That's not the case in most states in the US.
Yeah, they do not. They can get the form either the school can provide it or it's up online. And so there's no additional courses or anything that they have to take. They can just sign that. But our school nurse teacher association and our school nurse teachers here in Rhode Island really do try to work, through those things. If a child comes in without an HPV vaccine, they reach out to us or find out who their pediatrician is and try to actively work with them to try to get them vaccinated. But it's a pretty low bar to get a religious vaccine or religious exemption. But we do when we do our annual school survey every year, where we assess compliance to all of our regulations, kindergarten, 7th, 8th, 9th, and 12th. We do identify schools that we either see increases in exemptions or a decline in coverage, whichever way you want to look at it. And then we reach out to those schools, work with those school nurse teachers, go into those communities and try to see how we can bring those rates back up, address any concerns or questions that they might have.
Yeah, it's
I
really
would, oh, sorry, I do want to mention, like, when we were discussing the school mandate originally on the advisory committee, a lot of us pushed back hard on the concept of religious exemption in the first place, since, I think all of us know that there are no major religions that actually, recommend banning or somehow religiously ban vaccinations. So it has been, a conversation on getting rid of that in Rhode Island, though there just wasn't quite enough confidence that that would fly, so to speak. So I think it was left in place. I think a lot of it is, it's really more of a philosophical objection than a religious exemption, but, whatever you want to call it, I think it was felt that it would be too controversial to get rid of it entirely. But I think the way we handle that here is, the nice thing about Rhode Island is it's a small enough state and it has a good, very solid Medicaid program. So children in Rhode Island are generally covered, and most children in Rhode Island have a primary care home of some sort. And so I think the opportunities for those conversations to be had are good here. So I think that also helps counter some of the tendency to have families do the religious exemption in whatever form that it exists. And I think that is helpful here.
and religious
And
exemptions often happen out of convenience, where a child presents to register for school and can't, and so sometimes it's facilitated by people in the school who say, "Oh, well, then just sign this religious exemption." In my former state of Tennessee, you could literally write your religious exemption on a cocktail napkin and put it in. So at least, having to go through the step of going and finding a form and printing it out and signing it and turning it in probably does help to reduce some of your rates compared to some of those states where you really don't need anything except a signed statement on a piece of paper. But I imagine because you have your universal program too, that you don't have some of the barriers that other states have in getting kids vaccinated, because maybe a parent doesn't have to take off work if they can get a vaccine at their school when they're trying to register.
yeah, and we also see when we look at 8th and 9th grade HPV coverage rates and from our surveys, we actually do see a slight increase. So I think some of it might be parents not comfortable at 7th grade, but they're comfortable at 8th grade. And so they just kind of delay it a year. And then our numbers do kind of start to increase as the child gets older. And that might be a comfort level of the parents or a conversation between the adolescent and the parent, as that child gets older and gets ready to, leave the home onto the next stage of life. So that has been an interesting observation that we've seen over the years as well.
That really is interesting. Well, I want to thank you both.
Validate that as well.
Yeah.
There are a few that there's some that will just refuse completely, but there are some that wish to delay it. And then you just kind of see them say, I just want them to be a little bit older. And so that does happen quite a bit.
Well, I want to thank you both for taking the time to present on the webinar today. And I hope that we'll be able to see you again, Dr. Dietrich, and some other capacity. And let's go ahead and put up the slides and get ready to close this out. So there are tons of resources available around HPV vaccines. AAP, the Rhode Island resources at the Department of Health. AIM, our organization, has some resources, including a blog that I wrote recently about some of the recent research. Look at the HPV roundtable that is from the American Cancer Society. There's a lot of resources there, especially resources around vaccinating at age 9, including social media and other images that you can get to download to make posters or other visuals in your office. Next, please. And then we want to invite you to come back to the next webinar, which will be on back to school vaccination. So we're barely even getting towards being out of school, but no rest for any of us. We're going to jump right back into getting ready for back to school, take advantage of that summertime. So this will be on July 21st at 8 a.m. Eastern Time. We'll announce the speakers for that soon. And hopefully we can help give you some new ideas and motivation to get those immunization rates up as kids head back to school in the fall. You can also visit the Rhode Island Department of Health's website to view any of the previous Shot of Knowledge webinars. And if you'd like to request a certificate of completion, you can also request that through Department of Health. So I want to thank you all again for coming to this webinar. I hope to see you again in July. And if there's anything that comes up in the meantime, I'm sure they would be happy to have you reach out to Dr. Borgano at the Rhode Island Immunization Program to help you address some of those challenges around getting kids vaccinated. Thanks. See you soon.
Thank you.